Well, welcome back, everyone. We at I'm For Us are so pleased to see you here. But before we start this session, just wanted to remind everyone that we have about 10 minutes break before our closing for the day. And please come back after the break. That would be great. I'm pleased to be moderating today's session from values to practice, embedding health equity in integrative health with Dr. Vincent Minichiello, Yvette Couture, Nico Henderson, Dr. Charles Ship McNeil, and Marlisa Warren. Before we get started, we have a few housekeeping reminders. Please take a moment to review our community agreements posted in the chat. And please feel free to use the chat to introduce yourself or to share respectful thoughts, questions, or resources. Please post questions for the speakers into the Q&A function in Zoom. If you plan to collect CMEs for the conference, please take a moment now to fill in the Google form. Please be aware you must complete this Google form for each presentation in order to receive the CME credit. Also, please note that you must attend the entire session to receive the full credit. And now it is my pleasure to introduce Dr. Vincent Minichiello, who is a board-certified family physician and integrative medicine physician, serving as an associate professor within the University of Wisconsin-Madison Department of Family Medicine and Community Health. Yvette Couture is manager of the education program at UCSF's Osher Center for Integrative Medicine, working with a team to advance integrative medicine education and research, including NIH-funded training programs. Nico Henderson is the education program manager for the Osher Collaborative at the UCSF Osher Center for Integrative Health. Dr. Charles McNeil is an intercultural educator and equity consultant specializing in inclusive teaching, curriculum design, and organizational change. Marlisa Warren is the Integrative Health Equity Program Manager at the UCSF Osher Center for Integrative Health, where she leads initiatives that expand equitable access to whole person care through strategic partnerships, program development, and cross-sector collaboration. And now I hand it over to the panel of speakers.
Welcome, everybody. Thank you so much for being here to be a part of this session together. I'm just going to introduce this session. So the title is From Values to Practice, Embedding Health Equity in an Integrative Health Curriculum. And the learning objectives here, number one, understand the importance of applying an equity lens to integrative health seminars. Number two, review the intention, implementation process, and lessons learned from this particular project that we'll be talking about. Number three, the hope is that you might be able to critically apply the results of an equity audit case study as a core part of the transformational process elicited through this project. And number four is integrate these project reflections as a way to initiate or continue the application of an equity lens in your own local educational settings. Now I'll hand it over to Dr. Chip.
Thank you so much. Good afternoon, evening, everybody. I'm Dr. Chip McNeil, and I actually want to begin with an inquiry question that undergirds inclusive integrative healthcare. And that is, when we say integrative healthcare should treat the whole person, who are we imagining that person to be? Integrative health recognizes that health is not produced by one organ, one discipline, or one intervention. It is shaped through interconnected biological, behavioral, social, cultural, environmental, and relational conditions. And that is the promise of whole person care. So my argument is simple. That promise cannot be fully realized without an intentional equity perspective. Equity is not a topic beside integrative health. It is part of the essence that makes integrative health genuinely whole person, clinically trustworthy, and educationally effective. Next slide. So People do not enter healthcare systems from the same starting point. And the meaning of illness, healing, prevention, family, spirituality, disability, and wellness is interpreted through culture and lived experience. Access is mediated by language, geography, income, race, ethnicity, gender, sexuality, immigration status, age, and so much more, including prior experiences, both good and bad. If integrative health asks us to understand the whole person, we must also ask what surrounds that person. What makes health difficult to achieve? Whose knowledge is recognized as legitimate? Whose pain is believed? Who can afford the recommended interventions and who can take time away from work, travel for care, pay for medicine, or even safely disclose what they really need? So trust is paramount, and it's not a soft outcome. It affects disclosure, adherence, continuity, shared decision-making, and whether or not people return for care. So respectful communication, language access, culturally responsive services, and partnership with communities are therefore part of the quality of care practices. So the national CLAS standards offer us an operational frame. They say, care should be effective, equitable, understandable, and respectful. The strategy is to practice curiosity, humility, responsiveness, and repair. Well, how can you achieve that but through an equity perspective? And that is why an equity lens matters so much in integrative health education. Because we have to think about this critical question of how do we move equity from something we value and something we care about to something that we can confidently and intentionally apply to our work and to our teaching. In a pluralistic, multicultural society, faculty must be equipped to teach in ways that recognize difference, reduce avoidable exclusions, and help learners navigate the complex social, structural, and cultural realities that shape health and healing. Next slide. So, health education is where future clinicians learn what counts as knowledge, whose experience is central, and how authority is exercised, and what we do when differences create uncertainty or conflict. If teaching reproduces exclusion, then learners may absorb the idea that equity is peripheral to the clinical experience. But if teaching actually models inclusion and accountability, then learners practice the habits that trauma-sensitive, compassionate, whole-person care requires. So health educators must learn to look critically at their own teaching, at themselves, and think about this through a lens, an equity lens, in new and equitable ways of applying this concept. An inclusive equity lens examines the content, the lesson design, the teaching methodology. In the content, whose community and knowledge are being represented and whose is missing? How are case studies chosen? And what norms are they presented around? For instance, healthy pink rosy cheeks are not a universal sign of health. My cheeks don't look very rosy, but that doesn't mean I'm not healthy, right? Does language stereotype, pathologize, or use deficit framing? Are complementary and traditional practices examined with respect and appropriate critical inquiry rather than romanticized, dismissed, or casually dropped in the conversation? I'll just give you an example. For instance, you have to be specific and intentional when you reference people. Don't say Asian when you mean Chinese or Korean. Don't say people of color if you're actually talking about black people. Say black people. New slide. So the purpose of our initiative at Osher was not to prescribe ideology or evaluate faculty or require wholesale redesign of their educational content. Rather, it was to provide practical, presenter-facing tools that help faculty translate deeply held values into their everyday teaching experience. And our equity teaching toolkit that we designed specifically for this collaborative was designed to support presenters in applying an equity lens to their teaching while preserving their autonomy, their flexibility, honoring disciplinary expertise, and meeting educators at different levels right where they are. This work will look different in various contexts, and that's why it must be cultivated in a very specific way. Next slide. For me, this is about moving from awareness to action. We should see equity in the language of the syllabus, in the cases we select, who's invited in the room, how we facilitate disagreement, and how we assess learning and what we do when harm or misunderstanding might occur. So the question is not whether or not every educator will do this perfectly, it's whether our systems make improvement possible, whether they actually open the door for clinicians to have an equity-centered practice. And if they don't, then those systems have to change. Integrative health asks us to care for the whole person. An equity perspective asks us to take seriously the whole context in which that person lives, seeks care. Inclusive health education prepares us to do that work with humility, rigor, and practical skill. Now, I know what some of you are thinking at this point. You're like, okay, yes, equity, but these are dangerous words. These are perilous times, socially, politically, and certainly in the field of education. Very frankly, in my opinion, there is a war against equity and justice at the moment. An equity-centered project like this one may actually seem dangerous and uncomfortable, and rightly so. Actually, in truth, we are ahead of the curve right now. We are ahead of the curve, but that perspective is important because we have to start this work now because it takes years to develop these capacities and these practices. Our work is not mistimed. If you start this work now, it's not mistimed, it's visionary. In a volatile, often discouraging cultural and political environment, the resistance and hesitation you encounter are likely going to be unavoidable, but are consistent with what it means to lead meaningful change with courage, especially in times of chaos, rather than wait for the safest of conditions. The pendulum, let me tell you, the pendulum will swing back towards justice. The pendulum will swing back towards justice. And when the time is right, we can all be uniquely positioned to usher in this new dimension of integrative healthcare. And for that reason, we must attend to this. We must stay the course. And we must recognize when you do this work that you are leading, not following, and that the challenges of this work are worthwhile, timely, necessary, and forward-looking. So let equity become visible in everyday integrative health practice, and let our health education model the kind of care we want our learners to provide. Thank you. Now, I just gave you that little intro there, but you want to know a little bit more about our actual project. And to do that, I'm going to invite Nicole Henderson, the Education Program Manager at the Ocean Collaborative for Integrative Health, to take it up from here. Nicole.
So thank you, Dr. Chip. That was so inspiring. You've set me up well for my part. My name's Nico Henderson, and I work with the Osher Collaborative. I wanted to just maybe say a little bit about what that is for those of you that don't know. The Osher Collaborative comprises an international group of 11 academic health centers funded by the Bernard Osher Foundation to study, teach, and practice integrative healthcare. So Dr. Chip has grounded us in the equity, in why equity is essential to whole person health and what a comprehensive equity audit actually asks us to examine. So I will take us from that framework into what happened with our project. So next slide. Sorry, we're having technical difficulties. Okay. So I'll explain why we began this project, how we approached it, and what we learned, and also how we plan to carry the work forward. Next slide. So why did we do this? The Osher Collaborative offers a faculty fellowship in integrative health, which is a year-long virtual training program for physicians and advanced practice providers and they need to be working in academic healthcare settings. It combines integrative health education with clinical and scholarly mentorship. Our program helps our learners bring integrative approaches into patient care, teaching, and their institutions. Our fellowship was already building on a strong foundation of integrative equity. They are highly knowledgeable clinicians and educators who care deeply about equitable care. With that said, our review of the fellowship seminars revealed several opportunities for growth. We could deepen how considerations such as access, cost, representation in research, and structural drivers of health were woven into clinical content. We could also better support presenters at different levels of confidence, making context setting and positional framing more consistent, and help bridge the gap between understanding equity principles and then applying them in teaching, which is what Dr. Chip was talking so well about. That led us to our guiding question, which is how can we better equip our educators to translate equity-centered values into clear, actionable teaching practices across different disciplines and how to apply them to teaching, at various levels of experience. So strong institutional support from the Osher Center allowed us to give structure for addressing that very question. Next slide. So we organized the project around three connected components. First, we built a foundation through a three-part training series, which was open to the entire Osher Collaborative. This gave us shared language, a practical toolkit resource to share with everyone, as well as a map connecting the work to our integrative medicine core competencies, which were just revised. Next, we moved into specifically the fellowship curriculum. Our consultant, Dr. Chip, worked individually with 3 volunteer speakers using his equity edit guide to review their existing presentations. The examples and the learning from those sessions were then brought into what we were calling the curriculum transformation labs, which opened the same guided process that he did with the one-on-one speakers to all fellowship speakers in a group setting. The third component is ongoing. After the grant period ends, we plan to continue using these amazing tools and ideas in our ongoing work with speakers and then gradually apply them across the entire fellowship, across the entire curriculum in the fellowship. The goal is for equity to become a consistent thread throughout our program, not just have certain sessions include it and others not, or others more and others less. Next slide. So what did we learn in this project? It's been a year and a half, this project. We're coming up on a year and a half. And our biggest successes were moving from discussing equity as a broad principle to actual presentations and cases and speaker experiences. And along the way, we developed a shared language, practical tools, and models that we can reuse over and over. We also began to build our internal capacity to continue the work when the grant is finished and our support from Dr. Chip is over. Our challenges were largely structural, so synchronous participation was difficult. All of our seminars and curriculum transformation labs were synchronous. We really wanted to get everyone in the same room, but that was difficult across schedules and time zones. Clinicians also have limited protected time to participate in this type of thing. We also learned, I think, a lot, like a lot of grants, that our original scope was very ambitious for a 1 year. It's already been a year and a half, like I said. So this required us to prioritize the most useful components while recognizing that some elements will need to be further refined in the future. And, this is a work in progress. So next slide. To talk a little bit more about how we want to carry the work forward from this super important and gratifying project. We want to first adapt our comprehensive toolkit, which we've worked on this year, into shorter targeted RISE modules, meaning like online modules that we can gear towards certain audiences so they can dive right into their pieces. It'll become available for our entire Osher collaborative. Second, we will document successful curriculum revisions, lessons learned, and keep the practical examples. So over time, this will give our faculty, the ones that haven't participated in this, a concrete, example to follow, and a model for what equity-centered teaching can look like in different disciplines and educational contexts. So we'll have a large variety of models for them to appreciate and apply to their own work. Third, we want to build the internal capacity needed to continue to work after the grant period is over, like I said, and we don't have Dr. Chip holding our hand, which has been amazing. We want to embed the competency map and equity edit guide that he used with the one-on-one speakers into our existing speaker preparation. So I meet with each speaker to prepare their talk. So I'll be able to implement pieces of that as we get new speakers and improve the existing talks that we have. So this makes equity part of routine educational practice rather than a separate initiative. So finally, we'll continue applying and improving this approach. Each year, we plan to do like a deep dive with one or two speakers so that we can, really gather feedback and use theirs again as examples for the people coming up and coming in. So the goal is not to consider the project finished when the grant ends. It is to create the resources, examples, and internal structures that allow equity-centered teaching to become an ongoing part of how we develop and support our curriculum. So that's the project level view. That was our grant. I want to now turn it over to my colleague, Vinny Minichiello, co-fellowship director, who will take us inside one of the one-on-one equity audits. He was one of the speakers for our equity audit. So using his seminar as a case study, we'll see what his process looked like and what changed as a result. So off to you, Vinny. Thanks.
Thank you. Thank you, Nico, and thank you, Dr. Chip. I have to say, just as I'm hearing both of you talk about this project, I just feel this swell of joy and gratitude for being a part of this work together with this team. Thank you. Thank you. So I'll just share briefly about my part in this as one of the sort of case studies, test subjects. And I just wanted to identify too, this is actually a novel approach from what we could find in terms of, we did a literature review and discovered that this sort of equity audit that Dr. Chip guided us through has not been something that's been published, at least in the medical education literature. So it's exciting to be a part of this process and see how it plays out and how much it's affected me in my own presentation. So a little context here. I had been invited several years ago to present on chronic fatigue syndrome, or ME/CFS, in one of the virtual seminars for the Osher Collaborative Faculty Fellowship. I've been doing it for a few years. Dr. Chip took the materials. There was like a pre-recorded talk that I had from the previous year. He reviewed the materials that I had put together for the pre-seminar materials for the fellows, as well as the recorded actual seminar, and reviewed that. We had 3 meetings together, and I would say that really the intention that he helped set in those meetings was for me to reflect on kind of what I was hoping folks would get out of this, how my own positionality plays a role in the content that's developed, and how to make this better with a health equity lens. And through reflection, discussion, and review, He ended up coming up with a very comprehensive summary with many detailed recommendations that he invited me to implement, not all right away, but gradually over a period of time, picking one and then implementing that and then bringing it forward over time. So, just wanted to share a few of these reflection questions because I think sometimes the the learning comes in asking the question than necessarily like the answer or what is done. And my hope in sharing some of these questions is that these might be questions that you could consider in your own educational spaces that you're a part of. So one of the initial questions was, what's the original purpose of the fatigue module? And what did you want learners to understand and be able to do? And this was a question that what I took away from it was, uh, how can I be clear about my intentions here? I think sometimes I was noticing as I had prepared the presentation previously, is I sort of had this like unspoken intention of what I wanted to be conveyed in this particular seminar. And this question really invited me to say, like, to be really explicit and transparent about what's the intention, what are we hoping learners might receive through this particular seminar. And then in terms of equity and clinical application, what would it look like to teach fatigue in a way that preserves clinical rigor while honoring patient context? And again, I think this is an invitation to consider how education often has a bias towards um, what does this randomized controlled trial say? What does this systematic review say? And yes, those are valuable tools and valuable pieces to teach and talk to. And how is it that we can make sure that as we're educating, that we're honoring the context of a person's life, the social drivers of health, systemic drivers of health, and how that has a direct impact on people's experience of chronic fatigue in particular. The last one was challenges and tensions. What felt challenging or uncomfortable about integrating equity-centered questions into the module? And I think, again, just being aware of my own identity as a white cisgender man in the midst of an educational setting in this seminar talking about MECFS, how is it that I can be aware of not only my blind spots, but also like the spaces in which I'm striving to apply an equity lens and I might notice some discomfort, right? And what do I do with that? What does it feel like? What do I do with that as part of developing content and as part of doing the teaching for the seminar? Just wanted to share a few very specific lessons learned, broad changes, and then some maybe a little bit more granular changes. Number one, in terms of broad changes, was the importance of self-reflection, right? What is my own identity? Where are my own privileges? How is that showing up in the content of the seminar? And also just that reflection too, which leads to the next one is transparency, right? Uh, Instead of what I'll say is I've often experienced as sort of like the hidden curriculum throughout my medical school training. How can we be absolutely transparent about the intention of a particular module? What are the key takeaways? And being explicit and transparent about an equity and intention rather than just like having that woven in, having that be a very clear learning objective at the start of that seminar. And I think the other broad changes is like, how do we assess, right? How do we assess that this is landing or not landing with folks? And Dr. Chip introduced me to this educational models of doing a pre-assessment, doing a formative assessment during the seminar itself, and then a summative assessment at the end. Uh, and again, not having an education background, this is probably very simple for somebody who does have an education background, but for somebody who's like trained as a clinician, who has, I've found my way into educational spaces, uh, this was a really important and simple framework and set of ideas that I will be incorporating into this particular seminar. And just a few specific changes that I really appreciated. Good lighting, creating space on slides. Uh, Good lighting, and I talked to Dr. Chip about this too. It's not just about like making sure I look good on camera. It's about like the importance of my face being clear, my face being seen, my expressions being clear and seen as I'm presenting, and how important that is for folks to be able to understand me, to see me, to not be guessing about kind of what my intention is based on what's showing up on the screen. Creating space on slides, right? How do we make just the presentation of the slides as clear as possible, as straightforward as possible, not over cluttering them, right? And how important that's actually a way of teaching with equity, right? Making sure that these slides and the content on the slides is accessible, is understandable, is clear. Same goes with learning objectives. There's another specific one is being able to shape the case study to focus on key takeaway points. I think when I initially put together the case study, I just took verbatim a case of somebody that I'd seen in clinic, which I think outlined a few key points that I was hoping that learners would take away. And Dr. Chip encouraged me. He said, "Hey, if you can shift the study and put in different parts of the story such that the case more easily connects back to your learning objectives so that people are really being clear about like how does health equity weave into that particular case study. um, Doing that, changing the case study to make sure that those key takeaway points are present in that. And then I think the last piece that I'll share here before I pass it on is just sharing the racial identities in case studies and having a conversation about that. Dr. Chip and I talked about um, the importance of making sure there's representation within um, the case studies, within the pictures that are represented throughout the presentation. And I shared some uncertainty about uh, matching people of color with a particular disease state and uh, kind of over identifying folks of color with this state of being sick. And he shared like, yes, that is an important consideration. Absolutely. And, if all the people in the whole presentation are white appearing, how does that impact a learner's ability to see the patients that they care for in these case studies or themselves in these particular case studies? So these were some of the questions that we really dove into. And again, so much gratitude for Dr. Chip, his time and energy over and above to really walk me through this process together. And with that, I'm going to pass it over to Yvette and Marlisa.
Hello, friends. My name is Yvette Coulter. I am the Education Program Manager for the Osher Center for Integrative Health at the University of California, San Francisco. And this is my colleague. I'm going to scooch so she can be seen.
Hi, everybody. My name is Marlisa Warren. I am the Integrative Health Equity Program Manager, also at UCSF Osher Center.
Next slide, please. So we began our talk setting out 4 learning objectives. Now that we're just past the midpoint, I want to do a quick mapping check to review where we are on this journey. We started with the why applying an equity lens matters. The how, Nico shared the implementation process and lessons learned. We just were walked through an equity audit with this excellent case study. And now I want to get to the fun part where we involve all you on how to apply that to strengthen your own work. Whether it's in an educational program or a community clinic or even in your daily lives, these lessons. Next slide, please. Thank you. So, As we shared, our particular challenge was moving from commitment. Everyone in our program had a strong commitment, but to really implement the change and walk the walk. So how we did that is through practical tools, shared language, structured review process to help translate these ideas into our work and daily practice. These tools, of course, vary by setting and community, but the principle is the same. Equity needs to be sustainable, embedded into every day, rather than relying on individual champions or a particular project or course, things like that. And the other thing is our choices, the choices that we're making, what we include, what we emphasize, the voices that are represented. As Vinny mentioned, what is missing, the hidden curriculum. That communicates our values. These changes don't need to be large. We can start small. They can be as simple as how we frame a case, different contexts we provide, what questions we ask our learners to consider. And the other thing is to make this work last, to be sustainable, we have to really build it into every day. In our case, it's our educational processes. For those of you that do clinical practices, how you move forward in your clinic and engage with your patients. It needs to be embedded widely and not just on a project or a single person or champion. Next slide, please. So as you think about the work you do, your institution, program, clinic, consider where there might be already an opening to do this work. What strengths do you have? What barriers might you encounter? What is one place you could start to make a change within the next 6 months to a year? This could be professional development. It could be reviewing some presentations that you do. It could be revisiting onboarding with your teams, developing shared competencies, assessing how you structure team meetings, or simply bringing the right people to begin the conversation, folks in your communities. Perfection isn't the goal. We're always growing throughout our lives. It's really to identify the first achievable task and take that step, something that's meaningful to you and you can make actionable. And with that, I'm going to pass to my wonderful colleague, Marlisa, to discuss more.
Hi, everyone. So, as you have seen and has been described by my colleagues, this is not an immediate process. And what we're going to invite you all to do is to begin your process. You may have begun this process already in your individual settings and institutions. Wherever you are in your process, we're going to invite you to take one small next step. The next step, if you're already on the process, a new step, if you haven't begun the process. We're going to be taking you to breakouts. We're going to invite you to consider the questions that are on the screen. We're going to need a minute because you may have noticed we're doing a little juggle here despite all of our practice. We're using different technologies and computers and everything than we had originally planned. So in a moment, Yvette will put these questions into the chat and you'll have access to them. So you don't need to remember them. But what we're going to ask you to do is to go into breakout rooms. You'll have about 3 folks in your breakout rooms. You'll have about 10 minutes. And what we want you to do is consider some of the examples that you've seen. Consider what Vinny did. Consider some of the things that Dr. Chip outlined. Consider some of the examples that Yvette offered and take one small manageable thing and consider your next opportunity and have a chat with the folks in your breakout room. When you come back, depending on timing, we may ask you to put your some of your learnings from the discussion into the chat. We may ask some of you to come off microphone. And then we'll come back and hear what you have to say so we all get an opportunity to learn from each of you and from each other. All right. Enjoy your time in the breakout rooms.
And they will be there for 8 minutes, right? Okay.
Can someone in tech also broadcast the breakout prompts? Because I think people were moved before I could paste it in. Thank you. Besides, open your back on camera.
Trying to use this computer to do this thing.
You all are wonderful.
You're wonderful.
Brilliant.
Wonderful.
Just brilliant.
You are too. Thank you, Dr. Chip. Thank you, team. This is really
You're gonna make me sit in the middle now.
beautiful.
Yeah, hot
We'll,
seat.
we'll change. We'll rotate around. So you guys are like pushing me off.
I'm so sorry.
No, I loved it.
I needed your back.
Exit stage left.
The Gong Show, we give you the hug.
Exactly.
Leonie, that baby picture is so cute.
Thank you. It's not very professional, but I decided I don't care.
Renee, Michael and Conley says that he's in the room 11 and there's only one other person who's not responding and he wants to.
Oh, yes, I see. Okay.
Yeah, that's me, and I'm a she.
Oh,
Hi.
So
sorry. It
can
says
you?
Michael over here. Sorry.
I've lived with the name for so many years. It's like, okay, whatever.
Yeah, I can put you in another room. Sorry.
Great, thanks.
Thank you, Nita.
Oh, you're welcome.
Unfortunately, I had to break up the questions in different broadcasts. So they kind of got it in consider this question and this question.
That's okay because we don't need them to consider all of the questions, so it's totally fine.
Okay.
We're this is all jazz. This is all jazz.
Yeah. Great.
Yeah.
Thank you.
Yeah.
Okay, so we're at half point, I think. So I'm going to broadcast.
Thank you.
Thanks.
And
I have a question. So when you all finish, do we start the Q&A in this space, or do we go to the other
We want
room
to complete, like we had practiced.
in this space?
I mean, our lighting's better.
Depending upon the time.
Yeah.
Okay.
I don't
We'll try
see
to keep it
any
here.
questions here, though.
I think we can do it here because there's no session after this.
Oh, yeah.
So I think it's okay.
Thank you.
Can you hear me now?
Yes.
Okay. Sorry. Is that time over?
Not yet.
Not yet.
Not yet. We end at 5:19 or 6:19. So like a minute, 20 seconds. You can come back early though. It's not forced. Yeah.
Okay. Well, am I still in the breakout group?
Yeah, I see you there in room 18.
Room 18? I think I'm with Ellie.
Yeah. So can you click on breakout room on the bottom and join?
On the bottom, where do we click?
On the bottom,
Breakout
there will
room.
be either breakout room or more, and then breakout
More.
room.
Okay.
Yeah. And then
I
you'll
don't see breakout rooms.
You don't see breakout rooms?
No.
Yeah,
Okay.
not sure. Sorry.
Yeah, it's not showing up.
They're going to be ending in a few seconds, actually.
Okay.
Vinny, can you move us to our last or second to last slide, the next slide? Thank you.
Of course. And we technically, so we're going to have until 1/2 past, so like 10 minutes basically. I think, right?
I think a little. I think we get until 3:25, 6:25, 5:25. I think that's what we have. Is that right, Renee?
It's about right. Yeah.
All the times. Just gonna say
I
all
know
the
that
time.
I'm
Just gonna
very-
say all the times.
It's jazz. Yeah, we'll see. So do you want the slide up or should I take it down?
No, the slide can be up.
Okay.
Should be more, right?
Hi, everyone. Welcome back. I hope you found that to be a fruitful conversation. As we close, I just want to leave you with one piece. I don't know if it's advice, a learning, because we certainly don't hold all of the knowledge, and I wouldn't expect. I hope that that's not what you're taking from this. I hope what you're taking from this is that what we did that was successful was we started small and we built intentionally. And that's what we're hoping that you will take from this, that you can start with something, you can assess and start with one thing. You can start with one course, a lecture or case, and explore that one thing through an equity lens, that you can engage by bringing together your colleagues and your learners and your community. Because as we've talked about multiple times throughout the day, the community that you work with is critical. It holds the center. We can't do this work alone. It's too important and it's too difficult to do alone. So we need each other and we need to engage our colleagues and community. and that we really need to work to embed equity into everything that we do, whether it's our curriculum development. I'm not a clinician, I'm not an educator. I work to embed equity into my administrative practices. So I hope that those are some of the takeaways that you leave here with today. I hope that you are all entering some of the things you discussed in your breakout sessions into the chat so that the other folks in the room can learn from what you discussed, that we can learn from what you discussed. And I'm going to turn it over to Nita to see if there are any questions for us.
I don't see, thank you, Yvette. I don't see any questions here, but there are two comments, and specifically to Vinny. First one is, I appreciate the naming framing of white CIS gender and the realization of discomfort around doing this work. It is vulnerable and courageous to look right at it. I have definitely experienced this myself. And the other one is saying, thank you for walking us through your process with Dr. Chip. That's another level of meta, reflecting on teaching case studies with you as a case study, broadening perspectives. Let me see if there is anything. Yeah. I don't see any other
There's a question. I see.
there is one question here. I would love to ask Dr. Chip, what would you suggest as a potentially common starting point, even for diverse kinds of practices systems? Dr. Chip?
Yes, thank you for that question. I really appreciate it, and I deeply appreciate my colleagues and all that this felt so whole. It felt like a whole person presentation. You know, I'm often asked this question. First of all, I'm going to share something I didn't think I was going to share, but just for the people in this room, not for everybody. I went ahead and shared a document which will allow you to take that concept, that idea, and actually have some questions. As you know, Vinny was saying, these questions help guide your thinking. They help create a frame of mind and a habit of mind, a way of thinking. And so it helps you to critically look at it, because we can't ask those questions of ourselves. So these documents and these frameworks help us. So I put a document in there which is to help you post workshop to ask the further questions about the thing you're trying. Marlisa said it well. Choose one thing, start small. And I think it all starts with positionality. It starts with who you are. You are teaching things and saying things and using things and referencing things that have to do with your world, your mindset, the ways in which you have been socially constructed, and places that you don't even notice. And the question is, who am I? What am I saying? What language am I using? How am I talking about myself? And have I really presented myself and my relationship with this topic in an honest way with integrity? It starts with asking who you are and why you're doing the work, and what hidden biases, ideas, constructs you hold that you may not have noticed. And once you start doing that, then you see things in your life and in yourself that change the way you walk through the world. And I think it hasn't been said here, but you can't compartmentalize this work. You can't just do it at work, do it in clinic, do it when you're teaching. It will become who you are. When you have an equity lens, it's how you treat the person in the supermarket. It's how you address the server who comes to your table. It's how you acknowledge someone's background, their history, and you don't know their intersectional identities. So you have to pull back and address those assumptions. That's where you start. Who are you and what do you hold that you're not noticing?
There is one more. Selena is asking and wondering as to how
Yes.
many are feeling a need to do this under the radar of higher education and other institutions that are sacred in this political climate to do this work overtly.
That are scared to do this.
Yes. Yes. I spoke to this a little bit about the perilous times we're in. Here's the thing. When you start with yourself, nobody's looking but you. Nobody's noticing but you. But your practice will change. Your relationships will change. Then you find one partner, one colleague, one friend, one confidant, one relative to discuss this with, to help keep you accountable to the challenges you're encountering and the changes you seek to make and the revelations you hope to uncover. And you build a critical mass of a learning community from there, because 2 friends become 3, become 6, become 12. And you start small. And once there is a critical mass of people who want to see things done differently within your institution, your clinic, your setting, then you go to the people who have that most power and you say, here's what we believe, and here's what we think will change our practice and the impact we have on patients and clients. I'm not sure if that answered your question. I hope it did.
It didn't quite.
Okay, tell me what you're looking for.
That, and this is actually how we did it in my institution. In the small department that we have, we created a study group, maybe 5 years ago, 6 years ago, to look at this, because we each wanted to bring this in and to support each other and being able to look at our syllabi and bring in new readings and new ways of approaching things and to have that support from each other. And that actually was great. And I think it's made a big difference in our syllabi. There are some practices that we've instituted that we're starting to get some pushback on. And nobody said why we're getting the pushback, but we can all kind of guess why we might be getting pushback.
Sure. Yeah. So there is actually because this very issue you described we encountered it in our needs assessment. It's when there's an incongruency between institutional policy and your personal professional practice ethics and values. When you have that incongruency, you're going to experience dissonance. It's unavoidable. However, you will not find rest and respite unless you approach system systematically. We know why we get pushback. We all know. It's about it's about, I want to say money, but I don't know why I'm hesitant. It's about the numbers, and it's about money, and it's about compensation. It's about all these things. Is it truly about whole person care? And does that suffer because of the bottom line? You can't avoid these incongruencies, but what you can do is look at that whole system. Listen, I know people who've just taken just the intake form and they changed one question to make it more inclusive. They added a race that was not acknowledged, and that made one step forward. So you don't take on the big things. Don't take on the elephant. Take on the ant and start small and then work your way up. You don't lift 100-pound weights when you start working out. You start with a 5-pound and you build from there. So I can't encourage you enough to understand that what this work takes is courage. And if you don't encourage, I get this from Maya Angelou, one of my heroes, sheroes. If you don't have courage, nothing else can follow. You have the courage and willingness to try, the courage and willingness to fail, the courage and willingness to confront the system, the courage and willingness to confront your own biases and see yourself for who you truly are, the courage to stand up. Even if the system doesn't change, guess what? Your voice is heard and your point is logged. And the world will come full circle. Courage. I know I sound like I'm standing on a pulpit. This is really the way I talk. This is seriously.
You're awesome, Dr. Chip. Selena mentions, thank you for naming this. One example is our Honoring Origins in Mindfulness for Equity videos. We'll be discussing tomorrow. We felt it was important to ironically remove equity from the name in the video so that it wouldn't be filtered out of public engines. We are still doing the work, but we needed to adapt to promote access. And Annalisa also says, relating. Jude is asking, is Dr. Chip a pastor?
No, but I did grow up. I did grow up in a Baptist church, and I love those sermons. And I think I got a little bit of Dr. Martin Luther King and a little bit of my pastor in there. But I think there was something. What was the point that you made just before that about?
It was about the equity videos. Is that what?
Oh, the equity video. Okay, let's be honest. Okay, I don't pull punches. We changed the name of our session, the session you're in right now, because the word equity was too dangerous. And we don't want to put people in jeopardy. We don't want to put conferences in jeopardy. We don't want to put funding in jeopardy. And so here's what we know. We have to make compromises that allow us to get the word out, even if, right? You know where I'm going. You have to make those small compromises because the word still got out. I still said the word equity 100 times in this session. It just wasn't in the title. So change the title. Take the word out and still say and be what you want to be. That's what I say.
Thank you, Dr. Chip. I just wanted to say that was very inspiring, and it's helpful to be in a community where I can say equity freely, though, too. So,
Thank you.
Rosemarine says, yes, the word gets out and the work keeps getting done. And Elizabeth says, I like the idea of using this time to deepen our relationships with our allies in our neighborhoods and institutions. Yes, compromises to forward the mission, and I still grieve how sad it can be not saying what it is.
Mm-hmm.
There's one, let me see. Renee, it says there is a question in the chat by Jude. I can't see any other questions here. Is there any other questions that we have not answered or provided the comments? I don't see any. Jude, do you have any question?
No, I don't.
Okay.
I do just want to check and make sure that everybody who wanted access to the file that Dr. Chip put in there, did everybody get access? We also will download it and make it available to folks after the conference. Thank you so much, Dr. Chip, for sharing that. We really appreciate it.
Absolutely. That is my gift to you. I don't normally share things out of context and out of frame in this way, but this work feels so critical, and I can feel the energy in this room, and I can feel the purposefulness, and I can feel the intention, and I want to give you the tools to move forward.
Thank you for such a wonderful presentation here. And now I think we'll be ending our session, closing our day. Jude, I'll give it over to Jude.
Yeah, man, Dr. Chip, you are a tough act to follow. The last thing I want to do is talk about housekeeping right now. I'd really like to just let everybody stay with that. But one of the things that I would like to follow on and ask about in this audience right now, if there are people in this audience who are medical content writers or blog creators or anything like that, who are more familiar with the equity lens, we would really, really love to get some information from you. I'm going to ask you to email boardchair@iamforus.org. If you are someone who knows how to write medical content and is comfortable with asking some of these questions and wants to write medical content that is patient-facing, that is also deeply rooted in an equity lens. So if that's you, please reach out and email me at boardchair or next week, Cheryl, at boardchair@iamforus.org, because we would really love to know. And I just want to say thank you again so much to all of you. And for the courage, it takes a lot of courage to, well, I don't have to say it. We all know how much courage it takes to do this work, so I do not need to restate that. But I do just want to thank you all deeply, your group, not just for the work that you are doing and putting out into the world, but for sharing it with us. We're really, really deeply grateful for that. Thank you. And thank you for ending our first day today. This was an amazing way to end our first day. Thank you.